So I, had a patient who COVID positive at one point had quite involved lung involvement, recovered from that, but he was absolutely delirious. Okay. And we couldn't attribute that to like an ICU phenomenon, which we do see in a lot of patients where if you've been in an ICU for a prolonged period of time, you've been on medications, there's just like what we call a metabolic encephalopathy simply because of your infections, those sorts of things. You can see like a post-ICU sort of syndrome. That was not the case in this gentleman. He was very confused, and to the point that we couldn't safely downgrade him out of our intermediate care unit out onto a floor because he had to be on medications to address that severe agitation and delirium, those sorts of things. So what was really striking to me about his case was that as COVID went along, we started to recognize this like pro-clotting sort of phenomenon. So it all goes along with that inflammatory cascade from this virus that gets set off. And one of the things is that can make you, the phrase is hypercoagulable, meaning that your blood wants to clot more, okay? And so we started putting patients prophylactically, trying to prevent clots on blood thinners, which is a typical sort of process in a hospitalization simply because patients are relatively immobile when they're in a hospital situation. But even on higher doses, because of some of the lab tests that we started seeing coming back, and we started to see, clots, et cetera. So in this gentleman, lungs were recovered. He was fine. He was on room air, okay? He was on full dose prophylactic blood thinners. He was having neuro changes. And then about 2 days after I went off service, one of my colleagues was taking care of him, and his foot went completely pulseless. So he had clotted off an artery in his leg, and it was amputated that week. And that he's certainly not the only patient that we had that happen with. So to kind of get back to your question of, is this the flu? No, this isn't the flu. I mean, the vascular complications that we're seeing, some of the profound low oxygen issues that we're seeing, the neuro issues that we're seeing, I personally have never, I don't think any of us physicians have dealt with anything like this.
How well do you think we understand this thing now? It sounds like in the early days, we were still trying to figure out, what it did and how to deal with it. Do you feel now that we've got a good handle on?
No. I think the more data we gather, the more we actually are becoming aware how little we actually know. There was a study, there was a article that came out, I believe it was in the Washington Post or not that long ago, about an autopsy study looking at brain, kidney, lung, heart from about, I think it was 87 patients who had died from COVID. We're the micro clots in many, many, many organs. Areas of what we call ischemia, meaning deprivation of oxygen within the brain, okay? Not necessarily due to blood clots, okay? This is just simply oxygen didn't get there. We have a lot of concerns about patients who, were fine, came into the emergency room, swabbed, did not have an oxygen issue, went home as they should have and were directed to do, but got potentially pretty hypoxic, low oxygen levels. We don't know what that's going to mean for them long term. We don't know that yet. Increasingly, I'm not a neurologist, but I have colleagues that are neurologists, and increasingly there are concerns, are we going to see 30 years from now a cohort of people who have early onset dementia, neurocognitive problems? We don't know. I'm not trying to be an alarmist, but it's just to say, to insinuate that we have any idea about the long-term complications. Right now when we're talking about long-term, we're talking about in the order of weeks in terms of what we're seeing. We don't know years from now. You know, there's plenty of people who've, you know, they've had kids that they've done imaging on in other countries where completely asymptomatic, but had abnormalities on their chest x-rays. Do we know yet that those are resolved? Are these going to be people with scars in their lungs? I can't answer that for you.
Okay, so I'm guessing there's probably people watching this now who are thinking, "Holy crap, this could be really, really serious." And it's not. It's also, it doesn't sound like, oh, if you get it, you test positive, and then you recover, that you're like out of the woods forever. Like,
no, I don't think we know the answer to that question. I mean, I'm gonna give you an example of a patient I had. Okay, 23 years old, medical tech, like a technician in a hospital. Okay, not my hospital, but a different hospital. It was in the beginning of the pandemic when we didn't have great protective gear. She and 4 colleagues, other techs, I believe, I'm not sure, had a bad exposure. All 5 of them contracted it, according to her. I can't confirm or deny that. She came to me because she had gone and gotten swabbed at a third facility and was not hypoxic, meaning her oxygen was fine, and was told to go home and isolate. So she did that. She happened to have a pulse oximeter. So she was measuring her oxygen levels at home. She started to have problems. She was very short of breath. This is a 23-year-old who was a 10-mile-a-day runner with a resting heart rate in high 40s because she was so well conditioned. The long and short of it is that she ultimately made it to see me. And I will tell you, she had to have 2 negative COVID tests before we could safely bring her into our hospital. So you can imagine some of the difficulty of like trying to help people when they don't meet criteria for being in the hospital, but yet you don't quite know how to safely bring them into your outpatient practice without putting yourself, your staff, and your other patients at risk. And the good news for her was that she did not, at that point, by the time I saw her, her oxygen issues had resolved. Her imaging, her chest imaging, was actually normalized. But this girl was short of breath, extremely short of breath. And the reason is because she couldn't walk across my office without her heart rate hitting like 160. Okay? And I had no explanation for it. I sent her to a cardiologist, and the best thing that we can come up with is that the virus has caused like a dysautonomia, like an effect on how her nerves control her heart rate and some of the other sort of basic functions in her body. And so she's under the care of a cardiologist now. She's on medication to slow her heart rate. But I don't know long term, is she going to be able to come off of that medication? Is she going to be able to regulate her heart rate? Is she going to be a runner again? She's having problems with insomnia, headaches, these profound fatigue, those sorts of things.
You touch on another topic that relates to a lot of people's understanding of this problem, which is I thought even the data showed that most of the fatalities were occurring with much older people with pre-existing, other conditions. The example you gave obviously was not someone in a nursing home, but a 20-something-year-old runner. Are you seeing like a material number of people not in their 70s?
No, I wouldn't say, and so, I mean, and I think this is one of the messages that I kind of want to get out there is that, we can talk about mortality, which is death, and we can talk about morbidity, which is what's your quality of life. Okay. And so the data you're correct in terms of the mortality data. Okay. But we're not collecting, or we don't have a great sense at this point of morbidity data. Okay. So, you've got this cohort of people who recovered and we think they're fine. And I hope they're fine long term. We've got a cohort of people who have passed away from very severe cases. And then we've got a section in the middle ground where we already know right now they've managed to survive. But what is their life going to look like? And that's what I think people are kind of missing the boat on a little bit. I have several patients who are still admitted in the hospital now. We're hitting like day 70 plus of hospital admission. And these are people who I can't replicate the amount of oxygen it would require outside of a hospital setting for them to leave.
Oh my God.
Okay. So these are patients who were normal. One was an Uber driver. Okay. I think he's like 48. Okay. And he had a very severe case. And he will leave this hospital when he either gets a secondary complication or he gets a lung transplant.
Okay, so let's talk about prevention. Clearly, I mean, let's maybe for argument's sake, I'm pretty convinced you're a trained Johns Hopkins doctor, specialist in lungs. You've been working with patients now for months. So let's just stipulate that it is a big deal. It's more than the flu. It can have major negative implications, even if you're not obese and in your 70s. You could just be
Absolutely.
Right.
Let me just throw this out there. Let me just throw this out there too. I didn't take care of these patients personally, but I will tell you that we don't think there's a lot of morbidity in kids, but in my hospital there were 3 teenagers, 2 16-year-olds and a 14-year-old who were on ECMO. Okay.
What's ECMO?
ECMO is extracorporeal membranous oxygenation. So basically taking the blood out of the body, giving it oxygen and putting it back in the body. Okay. Oh. It's about the most aggressive thing that we can do to try and save somebody who's in hypoxic respiratory failure. Okay. 2 of them ended up with tracheostomies. So yes, they're alive. Okay.
Yeah. How are you when you're off work and you're just trying to live a normal life? What precautions are you taking? I mean, clearly you're convinced this is a big deal.